All right, I do believe we have a quorum. So thank you, everybody, for joining us this morning or this afternoon, wherever you may be. I'm honored to be joined by our guest today, Dr. Herbert Newton, who's a neuro-oncologist and medical director of the Neuro-Oncology Program and the Brain Tumor Center at University Hospitals Cleveland Medical Center and the Seidman Cancer Center. Dr. Newton has significant experience with GammaTile therapy, both at university hospitals and his previous hospital, Advent Health Cancer Institute in Orlando, Florida. Dr. Newton's published more than 220 scientific articles and book chapters. He's the editor or co-editor of 12 books in the field of neuro-oncology and neurology, and most lately is our esteemed guest today. So Dr. Newton, thank you so much for joining us today.
Thank you, Dakota. Appreciate the introduction. I'm going to go ahead and share my screen and start this webinar.
Excellent. Thank you.
So I'd like to thank everybody for joining me today to learn more about GammaTile therapy, a new method for brachytherapy of recurrent malignant brain tumors. As Dakota mentioned, I'm working at Seidman Cancer Center and University Hospitals Cleveland Medical Center. And when I was a fellow at Memorial Sloan Kettering Cancer Center a long time ago in the late 1980s, we were using the initial type of brachytherapy using I-125 radioactive seeds. And this was part of a brain tumor study group, a clinical trial. The seeds were placed with catheters, and it was a much cruder version of the type of brachytherapy that we can do now with the GammaTiles. These are my disclosures. So GammaTile therapy is the only FDA cleared treatment that's occurred in the last 12 years. We had Optune in 2011 for recurrent tumors, bevacizumab and temozolomide back in 2005. And again, more recently, we've had GammaTile therapy cleared by the FDA. And this is what the tiles look like. These are collagen tiles. They're 2 centimeters on the side. These things are square. They're pliable. You can maneuver them inside of the tumor resection cavity quite nicely. They have a textured surface. Oops, that's a mistake. Sorry. Textured surface on one side. This is the side that goes against the brain tumor tissue in the resection cavity. There's a smooth surface on the other side. The tile is 4 millimeters thick with the cesium-131 sources about 3 millimeters from the textured surface. And there's about 10 millimeters in between the 2 cesium-131 sources inside of the tile. You can see here how this GammaTile would sit on the operative bed. It's bioresorbable, it's conformable. It's unlike previous brachytherapy, like I said, it limits radiation dosing to the healthy tissue because of its structural collagen offset and because the tiles stay in place a lot better than they used to stay in place with the I-125 catheters. We're talking about dosimetry of roughly 60 gray to within 5 millimeter depth inside the brain tissue. And you can tell by this part of the diagram on the left that the radiation drop off is pretty rapid once you get away from the area around the tiles and past the 5 millimeter depth mark. So again, we're trying to reduce the amount of exposure of radiation to the healthy parts of the brain around the resection cavity. The cesium-131 sources have a half-life of roughly 9.7 days. And so within 6 weeks, 95% or so of the radiation dose will have been delivered to the area in the resection cavity. So again, this is designed to target radiation therapy at the area most at risk for recurrence, which is the area right around the resection cavity margins, trying to limit the exposure to the healthy tissue nearby. And as I'll show you in a minute, there's excellent data coming out in recent years showing good local control rates, very low rates of radiation necrosis. There's actually 4 clinical trials currently enrolling patients in this country right now. And this is covered by Medicare and most private insurances. And if you look to the right, you can see the radiation dosimetry diagram around the tiles in this given patient. And again, you can see that they're very conformal, very tight, so you don't have a lot of radiation spill off into the surrounding brain tissue. So this GammaTile implantation procedure is actually fairly easy and straightforward. I've got two films from two separate neurosurgeons to show you how these can be implanted. Integrates easily into the surgical workflow. On average, it takes 3 or 4 minutes to place these inside the operative bed. You can easily manipulate them inside the intraoperative area very easily. I'll show you that in a second. And typically, no special inpatient precautions are required. I'm now going to start this so you can see how this looks in the real world. How pliable the tiles are and how easily they go into the resection cavity. The surgeon can manipulate them very easily and place them where he wants to. And again, this format of brachytherapy allows this kind of placement and stability much better than we used to do with the I-125 catheter placement. This is another procedure by a different surgeon showing you how easily it is to manipulate the tiles around some of the delicate tissues in the field, including some blood vessels. So he's trying to place the tiles next to each other so there's no overlap. And you can see that the left pericallosal artery was manipulated pretty easily and carefully with the tile going underneath it without any difficulty. So again, you can see that that really isn't too difficult for the surgeon to put the tiles in place. And again, there's always a experience level that you have to attain, but in general, it's pretty easy to do. And so in terms of the workflow, you have a patient who's assessed as a candidate for tumor resection. You consider him for the tiles. You have to decide what the surface area of the surgical cavity is going to be, estimate the number of tiles you need, order the tiles from the company, and then the surgery and implant performed will be performed when the seeds are at their optimal radiation potency. And they will be ordered through radiation oncology at your facility. Here we have post-op treatment planning, therapy comparison between GammaTiles versus typical IMRT. The CT on the left is the patient we have been looking at so far that had their post-op CT there. You can see the tiles in place. And again, around the cavity very nicely. You see the GammaTile dosimetry, like I showed you before, is a very tight margin. There's very little spill off of radiation in the surrounding white matter and other areas of the brain that aren't involved nearby the tumor margins. To the far right is the IMRT radiation dosimetry. And there's definitely a lot larger field here with radiation spillover into some of the areas totally unrelated to where the tumor resection cavity is. Now, again, this type of dosimetry, which is so tight, is very good for brain mets. It's very good for most meningiomas. Sometimes if you have a glioblastoma, this type of tight field may not be perfect because there might be a lot of infiltration of the GBM into the corpus callosum or other areas within the white matter. So again, you would have to be careful about doing this in a GBM to make sure that the dosimetry would fit what's residual in the tumor. So overall, GammaTile is indicated for treatment for patients with newly diagnosed malignant intracranial tumors as well as recurrent intracranial tumors. This includes high-grade gliomas, metastatic brain tumors, meningiomas, and other associated brain tumors. The tumor has to be operable. It has to be someone who's a candidate for a major resection to consider using the GammaTiles. If you have previously irradiated tumors, you're not sure if it's necrosis versus a viable tumor, you would end up doing a frozen section prior to implanting the GammaTiles to make sure that there was a tumor there. And you can combine the tiles with other systemic therapies, including chemotherapy like temozolomide, bevacizumab, as well as with tumor treating fields. And you can look over here to the right, you can see that almost half of the tumors that have been treated thus far with GammaTiles are different types of gliomas. You also have about a third that have been brain metastases, about 10% are meningiomas, and then about 8% are other types of intracranial tumors. The first initial trial looking at this technology was performed at Barrow Neurological Institute. It was a prospective multiple histology basket design, single arm, and they implanted 108 implants into 96 adult patients with aggressive intracranial tumors for whom surgery alone was not thought to be enough to be curative. And most of these patients had failed at least 2 or more types of previous treatments before enrolling in the study. To the right, you can see the histologies that were treated. 52 were gliomas, 28 of those were recurrent GBM. There were also 35 meningiomas, 16 brain mets, and 5 other types of histologies. And so they performed a maximal safe resection plus the CZ131 brachytherapy GammaTiles prescribed to 60 to 80 gray at 5 millimeters. Most of those in the 60 to 70 gray range. And the endpoints were local control rates, overall survival, and toxicity. This is the first paper that came out from that initial trial, published by Brackman et al., Journal of Neurosurgery. And this was reported in 2019. And you can see below, there's one of the patients they treated, and ended up having that tumor right there that was then resected. You can see the post-op CT showing the implants in place. You can see their dosimetry lines with the magenta line being the 60 gray dosimetry line. And then to the right, you can see the post-op MRI scan with contrast, again, showing you where the dosimetry lines are. And if you look to the right, you can see a diagram of local control rates. In the black, shows what the previous local control rates were with therapy before GammaTile. And then above that in the brown is the local control rate that they were able to attain now with these meningiomas using GammaTiles. And again, it's much better and had a hazard ratio of 0.17 with a very significant p-value of 0.02. And so again, in the meningiomas with this initial trial, it seemed to be very effective and helpful for local control. This was the initial publication looking at the recurrent brain mets in that trial, published by Nakagi et al. And Curious in 2020. The diagram to the left is showing you in the magenta kind of the all sites local control, which is a little bit above 80%. Below that, you can see the control with tumors that were large, over 2.5 cm in size. And then above that at the top in the green is for local control with the tumors that were smaller and less than 2.5 cm, and those had a 100% local control rate by the time they published this. Even again, the tumors that were larger than 2.5 cm were still at 0.75% for local control, so quite good. To the right, you can see the local control depending on the type of radiation they'd had in the past. In terms of overall control, it was again a little above 80%. Even in the tumors that had had prior radiation therapy, it was still close to 80%. And then in the tumors that had not had any radiation therapy, it was 100% local control rate. So again, in this setting with brain mets, depending on the size and previous radiation therapy, can be quite effective in all circumstances, with most of these at 80% or above. This was another publication of using recurrent brain mets out of Memorial Sloan Kettering Cancer Center, published by Imber et al. They ended up having 20 patients, 24 operations, 25 surgical cavities. Median follow-up was a little over 1.5 years. Median diameter of the tumors was more than 3 centimeters. And about 80% had gross total resection or near gross total resection of the tumors. And if you look to the right, in terms of previous treatments, local control rate was about 50%. But once you got to this point where you used the resection and GammaTile, the local control rates were above 90%. So again, in patients with recurrent brain mets, this seems to be a very effective therapy with very good local control rates after surgery. In terms of GBM, the initial publications out of the Barrow with that initial cohort was 28 patients, locally recurrent GBM. MGMT at the time of recurrence was methylated and only 11%, unmethylated and 18%. The rest of them, they didn't really know what the status was. After surgery and GammaTile therapy, 17 patients then went on to get other systemic therapy. And 15 of those received bevacizumab, 12 received temozolomide, 8 received CCNU. Efficacy in terms of local control at 1 year was almost 50%, which in recurrent GBM is very good. Median overall survival was 25 months. Median post-implant survival was about 10.7 months. And if you looked at median post-implant plus systemic therapy survival was a little over 15 months. It was pretty well tolerated with only 4% of wound complications. And in this series, there was 7% radiation necrosis. At the bottom, you can see a very large recurrent GBM down there in the basal ganglia and thalamus region. At B, you see the CAT scan where it shows you the resection cavity lined by quite a few GammaTiles because this cavity is quite large. C gives you the dosimetry lines around the cavity with the initial MRI post-op. And then you can see at D what it looks like at 6 months, looking still very, very good. In E, you can see that the treatment site with GammaTile still looked pretty well controlled, but unfortunately the patient did have recurrence with growth on T2 flare to the contralateral hemisphere. This is still data from that Smith et al. Study we just looked at. And when they looked at their GammaTile therapy plus bevacizumab cohort, they had an overall survival of 16.7 months on median, which is definitely better than if you looked at external beam radiation therapy plus Avastin alone, resection alone, Optune, and then no treatment. So again, in this cohort of surgery, GammaTile, and then follow up Avastin therapy, there was quite good control. There was also another study out of University of Minnesota with recurrent GBM. They looked at 22 patients. All patients had a maximal safe resection plus GammaTile. They had a mean of 6.3 tiles implanted. So again, a lot of these tumors were very large. 0 reported cases of distant seed migration. Again, an issue that was happening quite a bit with the I-125 data in the past. They had 1 patient experience a CSF leak. They didn't have any incidents of radiation necrosis. Their median overall survival was 24.4 months. Median survival for the MGT methylated tumors was 37.4 months, which was pretty amazing. Survival for the unmethylated patients was still decent at 20 months. 6 months local control rate was at 86%. And at 12 months, the local control rate was at 81%. And these were tumors that had been through a lot of treatment. 14 of them were second recurrences, 8 had third recurrences, and all of them were IDH wild type. So all classical aggressive types of GBM. There was only 1 wound complication, and again, no episodes of radiation necrosis in this cohort. This is also data from that same study from Gessler et al. At University of Minnesota. Again, if you look at their recurrent patient data with median overall survival, again, they had 24.4 months for their cohort with resection and GammaTile versus 17 months for resection alone. So again, this adding the GammaTile did add to the median survival for sure in their hands. In terms of surgical adverse events in these initial papers, Wound infections were similar to what you saw with just pure brain tumor surgery, 2.5 to 4%. Dural closure related issues was pretty good at 2.5 to 4.5%. And then surgery related hematomas was actually quite low at 1.3%. In terms of radiation related brain changes, again, in terms of repeat compared to external beam radiation therapy and stereotactic radiosurgery, that ranged from 10 to 37%. Traditional brachytherapy in the past with I-125 ranged from 18 to 48%. And with GammaTile therapy, it actually is much better, around 8%. And again, a few studies haven't shown any necrosis or radiation-related damage. In terms of some newer papers that have just come out in recent months, we have a report from the Miami Cancer Institute using GammaTile for recurrent brain mets. This was Kutuk et al. And they had 12 brain metastases in 10 patients that recurred after external beam radiation therapy. Mean tumor size of 2.7 cm. Median follow-up was 14.5 months. Prior to GammaTile, the 6, 12, and 18-month local control rates were 66.7%, 33.3%, 25%. And when you compare that to the local control rates after they had had the GammaTile plus the surgery, that was actually 100% so far at 6, 12, and 18 months. You can see this graphed out to the right. And these changes between the before and after are very significant. The p-lab value of 0.001. They had one instance of grade 2 radiation necrosis and some surgery attributed complications to 2 patients, one with a pseudomeningocele, another one with some minor headache. So tolerated quite well. And in terms of local control rates, much better than their previous therapies, as you can see in the graph to the right. Another recent publication by Katlowitz and colleagues looked at a patient, a case report, who ended up having more than 20 brain metastases. And they ended up combining different types of treatment modalities. The patient had Gamma knife for all the small tumors. And then for the 3 larger tumors that you can see up along the top, he ended up having surgical resection followed by GammaTile placement. You can see the radiation spheres on the bottom left, showing that the radiation dosimetry did not overlap between the 3 sites there on the left side of the patient's brain. And this patient ended up doing very well and tolerated this multimodal therapy quite nicely between Gamma knife and surgery plus GammaTile. And so far has been tolerating it well and has been stable since the surgery. And then this is another bit of experience with brain metastases that were very rapidly recurring from University of Minnesota. This first patient had metastases from squamous cell carcinoma, did an initial resection, and then within 3 weeks had rapid recurrence and increased symptoms. So then they did a re-resection quickly after that, placed GammaTiles, and at 3-month follow-up so far, at least, there was no evidence for recurrence. So at least with early follow-up, patients doing well, or recurrence, they'll of course need to do further follow-up from there. They then had another patient who ended up having metastasis from non-small lung cancer while on alectinib systemic therapy. Surgery planning showed the MRI with the tumor growing very quickly with over 25% increase in gadolinium enhancement. So they ended up doing a resection plus GammaTile. And after the patient recovered, very quickly were placed back on alectinib. And again, is doing well at 6-month follow-up with no evidence of recurrence in the site of the GammaTile placement. So again, this patient also did quite well with their brain met GammaTile therapy. And so there are quite a few ongoing clinical trials with GammaTile. There's the registry, which is again looking at high-grade gliomas, mets, meningiomas, and others. There's newly diagnosed metastatic tumor trial, the Rhodes trial, comparison of surgery plus GammaTile. to surgery plus stereotactic radiation therapy for large newly diagnosed brain mets. There's also a recurrent metastatic tumor trial, which is investigator-initiated out of Sloan Kettering. And they're looking at previously irradiated mets that are planned for resection. And they're going to compare surgery plus GammaTile to surgery alone. And then there's a GammaTile study in newly diagnosed GBM where they would add that to the STUP regimen for newly diagnosed tumors, followed by external beam radiation therapy and temozolomide. And so in terms of my own experience with GammaTile, I mentioned the work I did with the older type of brachytherapy when I was at Memorial Sloan Kettering a long time ago. In terms of using GammaTile itself, I started working with these patients at Advent Health Cancer Institute from 2019 through 2022. We had a patient mix. The patients that we ended up initially treating were high-grade glioma patients at recurrence. We also treated patients with recurrent brain metastases after failing external beam radiation therapy or gamma knife. We also talked about patients with recurrent aggressive meningiomas at tumor board, but by the time I moved on back up here to Cleveland, no one had tried that yet with the meningioma patients, but again, it's might have happened by now. And so the patients that we did treat seemed to benefit. They extended progression-free survival and overall survival. They tolerated the procedure quite well. There really wasn't any radiation necrosis in patients that I saw, and there also weren't any wound infections. So at least in my limited experience with these patients in Florida, again, patients tolerated it well and it seemed to help them with good local control. In terms of the referral pathway, again, I think the best way to talk about this really is to have a multimodality discussion at your neuro-oncology tumor board, or if that's not available, refer the patient either to neurosurgery or radiation oncology for a discussion at tumor board, or at least a discussion between neuro-oncology colleagues. You could also consider referring them directly to your neuro-oncology group to see if they can review the case and bring it to tumor board for further discussion. That's how I've seen a few of these people here at Case Western and Seidman Cancer Center. There also is a GammaTile website where you can actually look at different cities and try and find the local physicians within those cities that have experience with GammaTile and can be referred for GammaTile evaluation. And now we have a couple of cases. This first was a 55-year-old male with colon cancer, had a 3-centimeter solitary brain met in the posterior right frontal lobe. You can see the pre-op scan with the enhancement there with surrounding edema. In the middle is the post-op scan, which again shows the GammaTiles in place there. You can see the tiles and the cesium sources there. And then to the right, it kind of shows you kind of how the tiles and seeds are placed inside of that scan. And this patient ended up having 4 tiles placed along the tumor bed. You can see the seeds in there as the MRI void artifact. Again, this patient tolerated the procedure well and is doing fine so far. This is a breast cancer patient at newly diagnosed metastasis. You can see that large left cerebellar metastasis on the pre-op scan. In the post-op scan, it was a very aggressive resection of that tumor. The cavity looks very clean. And on the right side, you can see the placement of the tiles with very good post-op dosimetry. Again, very tight margins for the dosimetry lines, which is very nice for brain mets. The patient had 5.5 tiles placed in the tumor bed. And again, the red line is a 60 gray prescription isodose line. And again, this is a very nice case with good tolerance. This is a 45-year-old with a grade 2 oligoastrocytoma that progressed to a grade 4 tumor. You can see the pre-op scan there, very large left frontal mass. Post-op ended up having a large resection with GammaTile placements. This patient had had a lot of treatment before with multiple craniotomies, external beam radiation, and a long course with PCV chemotherapy. This was early diagnosed back in 2012. By 2021, had this progression to grade 4, and then at that point had the craniotomy and temozolomide, and then had further recurrence with the craniotomy and placement of 8 GammaTiles. And again, they'll have to watch this patient closely. But right now, hopefully, they're going to be local control quite well for upcoming months. So, key conclusions. GammaTile is an FDA-cleared radiation therapy option for newly diagnosed malignant and recurrent brain tumors, including gliomas, brain mets, and meningiomas. Clinical data so far shows excellent local control rates, low rates of radiation necrosis, and there are 4 clinical trials actively enrolling patients in these tumor groups. GammaTile is covered by Medicare, most private insurance. Patients are actively searching for novel treatments. Is this one they should be aware of at their treatment site? And GammaTile gives patients a one-and-done radiation treatment option, minimal side effects, including hair loss, and has a reduced treatment burden in terms of time, travel, and cost. And I think I'm now open for questions. And so I'm going to go ahead and here's a reference list of all the treatment reports that I talked about during the talk. And I think that's the last slide. So I'm going to stop the sharing now and go back to Dakota.
Excellent. Thank you, Dr. Newton. That was a very comprehensive review of all the data available and including recently published. I'll now invite folks that are joining us today to use the Q&A function in Zoom to submit any inquiries they may have for Dr. Newton. We have a couple that we've already received, Dr. Newton, and selfishly, I'll kick us off. I've really appreciate the background experience and given your prior experience with former forms of brachytherapy in your past. I think it's fair to characterize some of those trials in the 90s as less than successful, so to speak. So what was really the aha moment for you, Dr. Newton, that got you interested in GammaTile in the first place?
Well, my experience with I-125 was a little bit disappointing in the fact that, using the catheter placement, you would often have the catheters moving around. And so the dosimetry would change. You would have cold spots with radiation where it wasn't as aggressive as it should be. It wasn't giving you the dosimetry to 6-2 gray like you wanted. You would have other areas where the radiation sources got too close together. And then you would have hot spots where the dosimetry was way off and they'd be getting much more radiation than they're supposed to get. And that caused some incidents of severe necrosis, where sometimes they had to have a re-resection of the necrotic brain area because of damage from the altered radiation dosing from the seeds. And so comparing that to the tile, where you've got this manipulable but still rigid structure of collagen holding the seeds in place, gives you much more careful dosimetry when you're placing it inside the tumor bed. Very, very low incidence of the seeds moving out of place and altering your dosimetry so that it's either less effective or more effective or too effective than it should be. And so that's kind of what got me interested in this approach to brachytherapy, the fact that it was just a better method of doing it with much more control of seed placement, seed stability where it's supposed to be, that kind of thing.
Understood. So it gives the clinical team a lot more control over, ultimately what they're trying to do is just deliver dose to those remnant tumor cells left over in the tumor cavity.
Exactly. And again, that structured collagen tile helps you do that a lot better than the old methods with catheters and that kind of stuff.
Excellent. Thank you. And as a neuro-oncologist, Dr. Newton, could you highlight for us, how do you get involved ultimately with patient selection for these patients that end up receiving GammaTile for their treatment?
We talk about everybody at Tumor Board. That's how we selected patients down at Advent Health Cancer Institute. That's how we try and pick the patients here at Seidman. So we're really talking amongst myself, my colleagues, the neurosurgical colleagues, the radiation oncologists. Everyone's got their opinion and trying to decide who's a good case, who's not a good case, who is someone we should try something else first and then maybe consider tiles later. We have a group discussion pretty much every time this is a possibility.
Interesting. And in those tumor board conversations, do you have any tips for folks on the call as to when they're having those conversations about all the different treatment options they could employ, what's the best way to advocate for GammaTile in the tumor board or within their peer group?
Well, I think it's a very good option, without too much debate for brain mets that have recurred through other types of radiation therapy and surgical applications. I think it's also a very good option for selected meningiomas when, again, surgery is a very good option. You want to go in there and do a resection. They've had progression through previous radiation therapy, possibly even previous chemotherapy. And the surgeon, can do a safe maximal resection. Again, in those cases, I think it's not a difficult sell to consider GammaTile, especially with the data coming out with the very good local control rates, as well as the fact that the dosimetry is so good for those types of patients. With glioblastoma, it's a bit more complicated because of the fact that they can have very strange, configurations of the tumor in terms of the part of the tumor that you might want to resect versus all the infiltrative areas around that. It might be something where the really tight dosimetry of GammaTile might not be a great way to do it. You might need something with a bit more flexibility in terms of really bizarre patterns of configurations of the tumor. But again, if you've got a GBM that's fairly circumscribed where that tight dosimetry pattern could fit, again, I think if it's failed a lot of other options, a good maximal surgery plus GammaTile is a very viable option, especially with some of the data coming out of Minnesota that I showed.
Yeah, absolutely. GBM unfortunately can tend to be such an infiltrative disease, unfortunately. And what we've seen in some folks, you showed the pie chart of
Right.
the first 1,000 patients that have received GammaTile. 48% of them were used for gliomas, most of which were GBM. With the Gestalt trial, which you overviewed for the group here, it combines GammaTile with that Schnupp regimen, where the patient's also receiving it at a later time, external beam radiation therapy. And so, have you seen, whether it's on trial or off trial, combinations of these therapies to address that challenge that you outlined for us, where GBM, if it's not circumscribed, it can tend to be harder to treat? Have you seen combinations of treatments with GammaTile in your practice?
I haven't so far, but I know people are looking into that. I mean, again, one of the worries that everyone has is that adding more radiation therapy, with the GammaTile to what you get with external beam still might not be enough to give you improved local control rates and improve survival in GBM. I think that study is going to have to show us if that's possible. Again, the initial I-125 trials with the seeds did not show a significant improvement in survival when the seeds were added to external beam radiation therapy. So again, those patients were getting huge doses of radiation therapy and didn't really get the expected improvement we were hoping for. I think that the judges are still out on what's going to happen with this trial for the same reason. It may not be that an extra huge dose of radiation with the GammaTile will be enough. I hope it is. Everyone's hoping it is. That's why we're doing the study. But it's not a slam dunk at this point. We have to see how the data pans out because, again, these are very radiation resistant tumors, and we've got to see if that extra boost of radiation is enough to make a difference.
Yeah, absolutely. Hopefully, we see, to your points, the same, quote unquote success in the de novo setting for GBM that we've seen in the recurrent. I believe you outlined 81% local control from that University of Minnesota study. Again, all recurrent GBM.
Right. And again, there's selection biases in there, and there's all kinds of things that are going to change that data compared to newly diagnosed all comers types of responses. So we'll see what happens.
Absolutely. And you outlined all the different tumor types that have been treated with GammaTile, both via published studies and in your own practice. Are there any particular histologies that when you interact with these patients, you immediately think, oh, this is potentially a good GammaTile patient, and what would be the reason for it?
Like I mentioned before, the dosimetry is perfect for recurrent brain mets. It's perfect for a lot of meningiomas that aren't really deep, and if they're accessible for surgery. I think there are some of the lower grade progressive recurrent gliomas that might not be a bad idea for, because they're not quite often as infiltrative as a progressive GBM. Again, you can look at lower grade astrocytomas, you can look at oligos, those kinds of things, again, might be decent opportunities to consider the GammaTile, because again, you might have better dosimetry with some of those tumor types. But again, you still got to check the MRI and see what the T2 flare is doing and kind of see how infiltrative it is. But in those kinds of patients, I think it's definitely, worth considering and discussing at tumor board.
Absolutely. I want to remind folks, please feel free to use the Q&A function if you have any questions for Dr. Newton. The next one we have is, outside of, histology specifics, are there other characteristics about the patients that might make them, more suitable for GammaTile?
Like with everything else in neuro-oncology, our younger patients, our patients that have a higher KPS, those tend to do better with recurrent surgeries, tend to do better with these types of therapies. Again, in some of the studies I was reading, to prepare for this talk, again, the KPS was definitely an issue, and people that were younger and healthier tended to do better with the surgeries and responding to the GammaTile therapy. So, again, if I've got someone who's 75 and frail and has a low KPS, I'm definitely not going to want to put them through a big surgery and GammaTile. Again, they might do okay, but chances are someone who's a bit younger and healthier and can tolerate things better would be a more optimal candidate.
Absolutely. The last question I have for you is around the cost effectiveness. Do you find, and how does your institution think about cost effectiveness, particularly for these new treatment paradigms? And would you characterize GammaTile as being cost effective for your institution?
Again, I don't think we've addressed that specifically. I know that there have been some other kind of cost effectiveness analyses done at other institutions that suggested that this was a cost effective way to approach therapy with these patients. We haven't done that specifically here or at Advent Health. But again, in other places, they have looked into that and felt that it was quite cost effective in terms of the lengthy local control rates, in terms of how easy it is to put the tiles into the patient, doesn't make the surgery a lot longer. There's a low rate of complications. So a lot of these things add into making it pretty cost effective and efficient form of therapy.
Excellent. Thank you for that. And then we have a question in the chat. Can you use Optune with GammaTiles?
Yes, it is. You are able to do that. Again, once the patient recovers from surgery and has their scalp back to normal, where they can actually put the Optune device back on, you would be able to use it.
Excellent. Thank you. And then for the patient experience, try to always bring these things back to the what matters most, and that's the patient. How do you find these conversations go when you're first introducing the concept of GammaTile to a patient in relation perhaps to, if they're a recurrent patient, to their previous treatment modality? How do those conversations tend to go, Dr. Newton?
The treatment's gone pretty easy, actually, because I tell them that, we can do the surgery, which the surgeon thinks you need no matter what. And then we can consider placing these tiles, which will then give you this big boost of radiation therapy. And then it's done. And it lasts for about 6 weeks until the tiles kind of run out of gas. And then you're finished. And that's a lot better than considering going through another 3 weeks or 6 weeks of external beam radiation therapy. It's not a difficult sell to have them consider the tiles. And again, we would show them the videos of like I just showed just now, of having the tiles placed so they can see what it actually looks like. And again, it doesn't intimidate them or scare them to see the tiles placed inside of a tumor resection cavity. It seems like they're like, oh, that doesn't look bad. And they don't seem to be too put off by it.
Interesting. And did that have any impact on your practice and what you're ultimately trying to do for that patient? But by that I mean, GammaTile being able to obviate the need for those repeat visits later on for external beam radiation. Does simplifying, so to speak, the radiation delivery have any implications to the care you're providing for patients?
Yeah, I mean, if I can get their radiation boosting done that easily and quickly and not have to worry about going through weeks of external beam or going through again, a repeat, radiosurgery procedures, that kind of thing, it does simplify things in the sense that I can kind of plan to get a hold of them sooner than later to plan for further systemic therapy, whether I'm re-challenging them with Temida or placing them on Avastin or trying lomustine or whatever it is. I can get back to that systemic therapy pretty quickly.
Fantastic. Thank you. Last call for questions. I think we've addressed all that have come in so far. So if there's anyone else that would like to pop a question into the Q&A function here. Otherwise, I can thank you, Dr. Newton. This has been very informative and comprehensive. Appreciate the mix of, overviewing all of the studies as well as giving us a real dose of your own personal experience, which started a few years ago. So
a long time ago, I'm afraid to admit.
You don't
yeah,
look
I'd like to thank everyone for joining us and participating in this webinar. This was I think a really great turnout, and we're happy so many people were interested in hearing about this. So thank you again very much.
Absolutely. And if you don't mind, there is one question that popped in here.
Yeah.
There seems to be a survival advantage with GammaTile in GBM over repeat external beam or focal external radiation therapy. What about sequential use of GammaTile in the future? And I assume they're getting to if the tumor eventually recurs, would you consider
in terms of using GammaTile more than once in the same tumor?
Yeah. Mm-hmm.
I think that's still open to question. I really haven't seen any published data on that or any case reports on that so far. Again, I think if there was enough time in between the procedures, it might be worth considering that. If the tumor grew back fairly quickly after GammaTile placement, I would think that the brachytherapy approach just really isn't going to work very well in that patient. Again, you're giving them 60 to 70 grade dosing within 6 weeks. If that doesn't hold it, I think you're going to need to try something else.
Okay, and then another one, can GammaTile be used in and around the pons?
It definitely would not be able to be used in the pons because, again, I'm not sure that's a really safe place to do surgery and resect a tumor anyway. I think that would be pretty catastrophic to do an actual resection within the pons. I don't think the tiles themselves would also be a great thing to do within the brainstem. I think most radiation docs and neurosurgeons would think that was pretty dangerous to try that. Everybody that I've seen that's had the tiles has really been more supratentorial or within the cerebellum. It really hasn't been within any of the brainstem tissue.
Okay. And I think that that does it for our questions. So last call, and now I can say thank you again, Dr. Newton, for joining us and giving us this great overview and answering all the great questions that came in from our audience. It's been a pleasure, and we really appreciate your time.
Thank you very much. Again, everyone, appreciate you participating with us.
Thank you very much, everyone.
All right, Dakota. Thank you.
Take care, Dr. Newton.
Bye-bye.